Excellent. Thank you, Brian. Thank you, everyone, for joining today. I'm thankful that we were able to put together this webinar and that we were able to line up these presenters. They've got some real-life, examples of sustainability at work. I know that during our peer-to-peer calls, for those of you who've had a chance to be on it, sustainability has been a top issue, and it's definitely something that programs are wanting to get ahead of. Depending on where you are in your implementation year, some of these strategies may really resonate with you in your efforts moving forward. And so to get us started, what I'd like to do is spend some time to review the framework that we're going to be using. I know that Brian had sent it out with the agenda as well, the actual assessment tool. And so what I'd like to do is spend a few minutes just to review what each of those mean, and then we'll get into the real-life examples here presented by your peers and colleagues. So we'll jump in. So the sustainability tool itself, the assessment tool itself, has been able to sort of lump sustainability or characterize it into 8 different domains. And so looking at this graphic here, you've got the 8 different domains laid out. One of the key features that I'd like you all to pay attention to and think about as we move through the presentation today is the fact that although these domains do present kind of unique and maybe individual components of sustainability, it's common to think about the overlap between these. For example, you see strategic planning right there in the middle, and what you'll notice is that each of these different components or domains of sustainability have some strategic planning that's required in order to really make the movement and effort and progress in each of them. And so, I'm going to go through each of these different domains, but also think about the fact that there is quite a bit of overlap, or there can be some overlap. And so as you start talking about things like environmental support, it's inevitable that you'll also start thinking about funding stability, maybe partnerships as well. And so, just something to keep in mind as we move forward. So we'll start with the first one, environmental support. And when we think about environmental support, and you all think about getting environmental support for your training programs, many of us think about champions. For those of you who are pretty far along in implementation, you think about all the work that it took to get champions, to get them hyped up about implementing this program, to really get them to see the value of the program, of the training components, of the skills of SBIRT within their different professions or disciplines. And so when you think about sustainability, a lot of it has to do with how do we keep that momentum? How do we continue to maintain that environmental support? And as we move into different avenues or different disciplines, how do we garner new environmental support for the initiative? How do we get folks in, and this is an example that came up during our peer-to-peer call, how do we get folks in dental professions to really see the value of SBIRT for alcohol use or substance use, right? And so thinking about what's in it for them, what is the connection, how do we generate that? And I think you're going to see some examples today about strategies for achieving environmental support. The next one is funding stability. Funding stability is an interesting one. There's a couple components. One of them is, as grant funds are coming to an end, what does it look like to replace those activities that are being funded? And so oftentimes this will require you to take a deep dive into your program and really see what are the areas that will be impacted the most by grants coming to an end and which areas may not be impacted at all. One of the things that we've seen programs do successfully is really be able to bake in the SBIRT training components. And so as you bake those in, they might require less funding to support them. And so again, you'll see some examples of that today. The other piece of this is looking at new funding initiatives. What are new funding initiatives that can be leveraged? What are other health professions training programs that are out there that are being funded where SBIRT makes sense to also include? And so that's kind of a brief overview of funding stability, but again, you'll see some examples here as we get through the other presenters as well. The next domain is about partnerships. This is an essential one. There's different types of partnerships that will support your sustainability. There are internal partnerships within your programs, within your training, your disciplines, within your schools. There's oftentimes partnerships with other disciplines as you start to work on interdisciplinary training opportunities. But there's also partnerships with external organizations. These might be your practice sites. These might be field instructors who you really need that investment from in order to really carry this out into the community and successfully give the students practice opportunities. And so there's a lot of different types of partnerships that may exist I think one of the keys that we see with partnerships is being really strategic, really knowing what the goals of a given partnership may be, what is the desired outcome. Oftentimes we have a lot of opportunities for partnerships, but some of them are more strategic than others, and so being able to prioritize those becomes important. Organizational capacity is the next domain that people focus on as they think towards sustainability. Again, this changes over time. I think as you reflect back upon your experience with implementation of the SBIRT training program, you see that organizational capacity was maybe focused somewhere different at the beginning. That may have been developing trainers for training students. It may have been developing infrastructure for conducting GIRA follow-ups. And now as you get into sustainability, that may turn into other types of needs for organizational capacity. For example, it may mean that you're looking at ways to institutionalize the SBIRT training components in multiple courses throughout a curriculum. Maybe it's developing some online modules or online components to make it easier to embed that within the training program. And so again, organizational capacity morphs over time, or can morph over time, and really paying attention to what you need now moving forward is going to be important. And again, you'll see some examples of this today during the presentation. The next domain for sustainability is program evaluation. How are we using the results of our program evaluation to support, whether that's messaging or obtaining support, environmental support from key partners? How are we utilizing that information? Some of the successes we've seen here is programs have been really good at using their evaluation data, whether that's student feedback, training outcomes, to inform program development and modifications. And so we've seen a lot of success there. Where it's become more challenging is using that to, impact funding stability. How do we then maybe generate additional funding? How do we use this information to support that component of sustainability? And so program evaluation, again, is key. Getting beyond improving program and looking at, funding stability is one of the challenges that we've seen with programs. So something to keep in mind. How do you achieve that? Program service design is the next one, and this is also known as program adaptation, right? As programs move forward, as they evolve, they will adapt to different things. Some of the adaptations we've seen with programs is within the context of the opioid epidemic. How do we shift the skills and the training that we're providing around SBIRT to help meet the need around opioids? And so some training programs have looked to combine them with things like in the naloxone education and other emerging areas that also kind of utilize those same motivational interviewing skills, some sort of brief intervention, and some sort of referral to treatment process. And so how does the program evolve to meet the continuing and emerging needs? And so again, you'll see some opportunities here within today's presentation about ways that that's happened. We're always glad to offer other ideas and concepts and sharing. So we're really thinking, how is this going to change? The other major change we see programs take on is around interprofessional training. How do we start to get our students to think interprofessionally? How do we get them to collaborate on cases, to work together and really provide holistic treatment? And so that's one of the other adaptations we've seen folks take on. Communications is another key strategy, or key domain, of sustainability. And really it's about being strategic. What are the areas as you think about the assessment? If you've done one of these assessments on your organization or on your training program, you may see some of the areas where you'd benefit from enhanced communications, more strategic communications. Oftentimes we'll see communications connected with program evaluation, and that you've got some data. How does it make sense to communicate it to folks? Who are the folks we need to communicate it to in order to support sustainability? Is it department heads who we need to garner support from so that they can continue to provide training to students and include it in the curriculum? Is it external organizations that we want to implement SBIRT so we can give our students practice? And so again, thinking about communications in a very strategic, outcomes-oriented way is essential. And lastly, strategic planning, as I mentioned, this is the one that kind of ties it all together. Key is here to have a team building a team that's really looking at sustainability, looking at these different domains, and finding ways to connect efforts and really looking at goals and outcomes. I think that's probably one of the more critical messages that we tend to convey to folks, is making sure that you're really outcomes-oriented, goals-oriented in your efforts. And through that, you'll have a nice, concrete sustainability plan that is very strategic. So that was a brief review of the framework. The assessment tool is something we've got as well. We encourage you guys to take a look at it, and now I'm going to hand it back to Brian so that we can move on to the next stage where you'll actually see some of these domains in action.
Thank you very much, Carlos. So I'm going to turn it right over to our next presenter. By the way, if you did have questions or comments for Carlos, please, again, save them for the end. We will be taking questions for all the presenters at the end today. But let me introduce Dr. Anna Mitchell, who's been leading one of the University of Pittsburgh SBIRT programs. This one focused on nursing training, but also training some other professions as well. So I'll turn it over to you, Dr. Mitchell.
Great, thank you. It's a pleasure to be here. Next slide. And I'd quickly like to thank Dawn, Brian, and Joan, who, along with others on the SBIRT team here at the School of Nursing, participated in our SAMHSA site visit to discuss sustainability. Next. So our objectives for this part of the webinar are to discuss how we embedded SBIRT into our nurse practitioner curriculum, the work of the SBIRT Nursing Consortium, our communication and dissemination strategies, and how we achieved buy-in at different levels. Next. So our SBIRT program goals were to integrate a sustainable and replicable substance use education and skill building program into our Doctor of Nursing practice program. And ultimately, we wanted to add 120 nurse practitioners to the workforce, including students, faculty, and preceptors who had the skills to identify and provide services to patients with substance use issues. And ultimately, we want to see how these skills translate into practice. Next. So to date, we have trained over 300 student nurse practitioners, and this is having them be able to take all of the modules, including overview, screening, brief intervention, case studies, and referrals. We've trained 15 Doctor of Nursing practice faculty and over 200 preceptors and community leaders in both nursing and social work. Next. So in terms of the sustainability framework and their target domains, I will be touching upon environmental and organizational support, partnerships, and next, communication and strategic planning. Next slide. So one of the first issues that we had to face was an already overcrowded nursing curriculum, and that no one faculty would be able to give us all the time we needed to integrate SBIRT into it. So what we were able to come up with was a way to provide an overview of SBIRT and then to separate out each of the different components of the process for inclusion into different core courses. And these courses are mandated. They are the core courses that every nurse practitioner student must take. Next. So because our grant was focused on really substance use across the lifespan, the next thing we needed to do was figure out how and where specific information related to adolescents, women, and geriatric substance use could be embedded and then integrated into those particular courses. And as Carlos mentioned, because of the opiate epidemic, we also felt strongly that we needed to address this issue and medication-assisted treatment. and we were able to integrate that information within the advanced pharmacology course as well. One of the things that we tried to do is to use multimodal teaching strategies as we integrated SBIRT throughout these courses. Next. And lastly, because we really want to ensure that SBIRT is translated into clinical practice, we encouraged our students to use it in their clinical practicum courses, which again, every nurse practitioner student must take. And we had the addition of screening, brief intervention, and making referrals into the Typhon student activity tracking system. So we were really able to keep track of how many students did how many screens and how many brief interventions, which was really kind of exciting to see those skills being utilized. Next. So I want to switch gears for just a minute. As we were getting started, my colleague, Dr. Deb Fennell from Johns Hopkins University, also received SAMHSA funding. And she convened a group of 30 nurse leaders from 24 academic and healthcare organizations to advance substance use-related knowledge and competencies among both undergraduate and graduate students in nursing. And today, there are more than 75 academic and healthcare institutions interested in moving this work forward, including a number from international countries. Next. We have also been fortunate to build upon the relationships that we have had with both state and national organizations, all of which have been actively involved in disseminating substance use and SBIRT information over a number of years now. Next. In terms of communication and dissemination strategies, we have a long-standing and ongoing relationship with our School of Social Work and a number of health provider systems within the community encouraging the implementation of SBIRT. Currently, we have formed partnerships with the university's 6 schools of health sciences and hope to increase our students' interprofessional educational opportunities in the years to come. Next. Our program staff have participated in and conducted numerous webinars, podium presentations, and poster presentations with associations and partners. The Nurse Practitioner for Women's Health Coffee Break Series, although funded with a CDC grant, is a short 7-part series on preventing alcohol-exposed pregnancies with the ultimate goal of the prevention of fetal alcohol spectrum disorders. And so it doesn't really matter where the funding comes from. We are collecting and collating all of these dissemination activities for others to be able to utilize. Next. Along with student, faculty, and preceptor outreach efforts, one of the other things that we have done is reach out to community agencies. For example, providing educational programs like Alcohol, Meds, and Me to the senior citizen centers around our area and in some of our rural communities. And over the years, we have developed a number of resources and have a sustained SBIRT website where these resources are readily available and free for others to use. Next. Since getting our grant in 2014, we have had over 24,000 hits on our SBIRT website with about 20,000 unique visitors. Next. And this is a list of downloadable resources. And as we speak, we are updating our site with even more materials that have been developed and links to our archived websites. Next. We do begin teaching SBIRT in our undergraduate program, and for those students who attend one of our graduate programs, they immediately become student SBIRT champions, both championing SBIRT within their clinical practicum sites, as well as through their evidence-based practice projects and dissertations. Faculty remain involved and committed through seeing the value of substance use knowledge and SBIRT education in their courses, and I think really because we have allowed them to be so flexible in how and when they integrate the information, they really have become faculty champions as well. And in terms of the administration level, here at Pitt, SBIRT is not going away because it is in so many courses now, and it really cuts across every department within our School of Nursing. Next. A challenge we do face is when our faculty nurse champions either leave the university or are beginning to retire. So getting new faculty trained and establishing buy-in is really important. Continuing to reintroduce the materials and its importance within our monthly Doctor of Nursing Practice Council meetings has been a big help and really begins to get the new nurse faculty on board. We also continue to work on the development of online modules, webinars, and the offering of continuing education credits for our faculty. And lastly, right now, we continue to think about how we can best take advantage of social media activities to reach our current students and to stay in touch with our recent graduates. Last. Thank you so much, and I think, as Brian said, we'll be taking questions at the end.
Thank you very much. So while we're in transition here, I did want to go back to the results of our poll from the beginning. Early on, I hit the button that should have made the results appear on everybody's screen. You might have cleared that out of your way by now. That's okay, but let me just, I'll share what I see here, which is in terms of the role of the attendees, we have more project managers and coordinators than any other role, with about 10 of those folks, and then next we have a roughly equal amount of project directors and evaluators, and then we have some faculty and instructors with us also today, and a few that marked other. In terms of the professions that the programs with us today train, social workers and nurses were the two most common, just nearly tied, and about twice as much, or maybe, yeah, about twice as much as the next grouping, which is medical students, and that was actually also tied with allied health. And then medical residents and pharmacists were also about equal as the third grouping, which is about, less than those first two groups that I mentioned there, and a few indicated other as well. So more social workers and nurses, and then the second most would be medical students and allied health, and then the third would be residents and pharmacists. So thanks everybody for filling out the poll, and so let's move on to our next presenter then. Okay.
Thank
so
you.
Let me,
go ahead.
Yeah, go ahead, Dr. Amodio. So let me introduce Dr. Amodio, and she's Professor Emeritus from the Boston University School of Social Work, but has been a key part of the sustainability planning and a key part of the SBIRT program there. Thank you, Dr. Amodio. Please go ahead.
Thanks, Brian. First slide, and I want to tell Anne that I found her presentation very interesting. Thanks so much. Next slide, Brian. So our project involved collaboration of our School of Medicine and Social Work. And so our trainees were social workers in our MSW program, mental health counselors, and psychiatry residents from the medical school. But in today's discussion, I'd like to focus just on the social work component. I'll describe the elements of our project, discuss 3 challenges we faced. The first, SBIRT availability to students. Second, engaging field instructors. And third, getting buy-in from student internship agencies. And finally, I'll talk about using the sustainability assessment tool and discuss methods underway that we use to address these challenges. A key part of our initiative is a 4-hour online SBIRT training module, and that covers all of the elements: overview, screening, brief intervention, and referral to treatment. This is incorporated currently into a required second-year clinical course for MSW students entitled Alcoholism and Drug Abuse Assessment and Intervention. This SBIRT training specifically addresses ways social workers can integrate SBIRT into their agencies. As the social workers on this webinar today know, there's no natural fit between SBIRT procedures and the usual intake and assessment procedures in many social work agencies. That is, it's not usual to conduct initial screening using standardized questionnaires. Next slide, Brian. So we wanted to introduce SBIRT earlier in the curriculum. It's currently not available to students until their second year, and this is close to the end of their MSW program. For sustainability, we wanted to make it part of the required first-year curriculum for 2 reasons: because more faculty would be aware of it and more faculty would teach it. In our first-year required courses, the sections are always taught by several faculty, perhaps 10 or more, so they would need to learn, the faculty would need to learn SBIRT in order to teach it. Next slide. Our second challenge was engaging field instructors. Although SBIRT, this online training, was designed for MSW students, we also designed it for field instructors who provide supervision to our students in the internship agencies. Field instructors are in key settings, a whole range: hospital, mental health settings, schools, agencies serving teens, the elderly, pregnant women, etc. Really a very broad range of agencies. For field instructors, our training is currently free of charge, and it provides continuing education units from the National Association of Social Workers. However, we found that the enrollment of our field instructors was not robust. Next slide. So we puzzled about this second challenge. Our field instructors work for the agencies or institution where our students are placed. They don't actually work for Boston University. So how to influence them to take the SBIRT module and then teach it to students. If all of them completed the SBIRT training, they could provide guidance and skill practice to students in how to use SBIRT, and potentially they could improve screening and brief intervention practices in their setting. So this would be terrific. Next slide. Currently, field instructor completion of the SBIRT training is totally voluntary. For sustainability, we needed support from a large number of them to be sure that the trainees had an opportunity to use SBIRT and that they received supervision on how to use it effectively. Next slide. We had a third challenge as well, which is buy-in from the students' internship agencies. We don't have specific partnership agreements regarding SBIRT with our students' placement sites, and there are about 400 sites. Such agreements would reinforce the need for SBIRT training for all staff, not just the field instructors or the students, and it would ensure that SBIRT would be conducted systematically. This is really a monumental task if you think about developing these kinds of agreements. Next slide. So how can this assessment tool be useful to us? I'll discuss 4 domains of sustainability, especially relevant to our project. The first is environmental support, maintaining a supportive internal and external climate. Next slide. So we answered the questions, are there champions in the system, and is this a priority for the leaders? And our answers were yes. We have strong advocates within our system, the Dean of the School of Social Work, the Director of our online MSW program into which SBIRT is embedded, the Chairman of our Clinical Practice Department, our clinical faculty, and the Coordinator of our Addiction Research Center. Next slide. Do they see that there is value added? Definitely. The SBIRT training was seen by leaders as providing value added in the clinical curriculum specifically. It's an example of a protocol for screening in a critical health area, so it can be an example for screening in other critical areas. It provides a self-contained process for evaluating client needs and taking steps to address them. And it models a non-confrontational approach, reduces stigma, and improves clinician and client communication. Next slide. We proposed moving the SBIRT training into the first-year required clinical course called Introduction to Clinical Practice with Individuals, Groups, and Communities, so that every MSW student would take it and take it early in their curriculum. We wanted some method where it was truly baked in, as Carlos said in his overview, and so it would continue ad infinitum, year after year. Currently, when students take the course, they complete a 10-question quiz in order to pass. So there's a competency measure embedded in the SBIRT course. Next slide. So in order to try to get this SBIRT module embedded into the first-year course, we held meetings with all social work faculty and the clinical faculty in particular to demonstrate the capabilities of the online training. We elicited agreement from the clinical faculty that they would review the training content and consider it for use in this intro course. After doing that, they agreed it should be embedded in the first-year course, and they were agreeable and enthusiastic about teaching it. As it turns out, this morning I heard that there's been a little bit of backtracking on this, and moving this into the first-year course may be delayed by a semester. And I'm sure people attending this webinar can identify with this kind of issue when you're trying to get full institutional buy-in. Next slide. SBIRT will continue as part of the Advanced Addiction course. We had thought that it would be good for students to take it in their first year course and then again just before they were graduating from the program in the Addictions course. In the Addictions course, which is many months after they enter the program, they are expected to demonstrate a higher level of proficiency. This is where it's currently embedded and they need to demonstrate in a live classroom that they can conduct SBIRT, and they have to integrate SBIRT knowledge into written assignments as well as these skill demonstrations. Next slide. Concerning the second domain of the assessment tool that was of relevance to us, partnerships, cultivating connections between the program and its stakeholders, we answered 3 questions. Do you have the necessary organizations as partners? We said yes, partially. Does the program engage and communicate with those leaders? Yes. And are these partners committed to the program? Yes. Next slide. Our major partner is the Center for Aging and Disability Education and Research. We call this CADER, a Boston University Training and Research Center that reaches a national audience of human service workers. These workers are primarily non-degreed or don't have advanced degrees, and they're working with older adults and the disabled. These human service workers already take a variety of online courses from CADER through their agencies or as individuals, and they receive certificates of completion. Next slide. CADER has the organizational capacity to reach a national community through Boston University's online training technology. They've offered educational courses for human service programs over a 15-year period, and during that period they've trained about 20,000 human service workers from 450 agencies and organizations nationally. Next slide. CADER often partners with state agencies and other large organizations, for example, area councils on aging. Their training already addresses substance use disorders among older adults, although it doesn't address SBIRT specifically and not in any detail. So the SBIRT training would fit nicely into their programming. This is what they have told us, and we can see a natural fit there. The CADER director is part of our SBIRT steering committee, and we've been working with her to make SBIRT available to these CADER audiences. Next slide. Thinking about the next domain of the assessment tool, organizational capacity, having adequate organizational infrastructure to manage and conduct the program. We definitely have a strong capacity for sustainability of the formal MSW curriculum. Since SBIRT training is online and supported by administrators of our online program and the dean. So this will continue to be an integral part of the MSW program. Given the online nature, it can be used and updated indefinitely in required and elective courses. Engaging more field instructors in completing the training would ensure that students use SBIRT at their sites more systematically and with more precision than if the field instructors were not involved. So we're brainstorming about incentives to encourage this. The current incentives for field instructors are continuing education units. The course is free of charge. They certainly have increased mastery in supervising the MSW students around SBIRT and substance use issues, and they have an improved ability to help their own clients. Next slide. So we've thought of a number of ways to try to expand the pool of field instructors. We have the option of offering field instructor seminars on SBIRT, and we plan to discuss this with our field education department this fall. Some other ideas are that we could conduct focus groups with field instructor representatives to have them help us generate ideas about additional incentives. And we could have university and school publications feature agencies that have successfully integrated SBIRT, and we could feature the field instructor leaders who are heading these initiatives. Next slide. Concerning buy-in from the student internship agencies, one possible strategy is to target certain sites. The larger ones, the ones who are using SBIRT to some extent already, ones that have a mission in line with SBIRT goals, and ones where the field instructors have received SBIRT training. Given the drug use epidemic, hopefully we can capitalize on the agency's felt need to get more training in this area. We know that some of these agencies are desperate for methods to address substance using clients. Next slide. And the fourth domain, communications, developing mechanisms for strategic communication of qualitative and quantitative data within programs and with outside stakeholders. We plan to disseminate outcomes by presenting jury papers and posters at fall and winter conferences of professional organizations. We've had some abstracts already accepted for the fall, and we have done this in the past 2 years and found it very successful. We presented for the Council on Social Work Education, the National Association of Social Workers, the Association for Medical Education and Research in Substance Abuse, and the Addiction Health Services Research Conference. And in each of these efforts, we found the audiences were really interested and enthusiastic about SBIRT. For some of them, it was they hadn't known a great deal about it, and they were particularly interested in online modules that could convey the SBIRT information. Next slide. I'd like to thank the BU SBIRT team. Everybody's worked very hard on this, and we really appreciate the efforts. And in the final slide, if people want more information, my email address is here. Thanks so much for attending this webinar today. And thanks, Brian.
Thank you. Yeah, and it sounds like, you know, the Cater partnership was kind of a special opportunity for your community, and I guess that shows for everybody it's important to do like an environmental scan of those partnerships to see what kind of unique organizations might be out there that can give you that edge in your partnerships. Very good.
Yes.
Thank you very much.
Excellent point. Thank you, Brian.
Okay, so I'm going to turn it over to our next presenter. As a reminder, put your questions for Dr. Amodio in the chat, and we'll take them at the end. Our next presenter is Dr. Niranjan Karnik, and he's going to present to us about how at Rush University Medical Center they've been able to really make the case for how SBIRT builds value in the institution there. Dr. Karnik?
Hi, thanks, Brian. So thank you for inviting me to present as part of this group. I think what you've heard are two, my very distinguished colleagues who really have done very well with their programs. And I'm going to take you through a little bit of a history of the program, but my presentation is going to be a little bit different because I'm not going to really focus on a training approach to this per se. It's really about how we sort of built from our SBIRT training grant into a broader philosophy for our institution, and now the training piece has become subsumed by that and exists within that. So here's the kind of brief history of our program. We were awarded our SBIRT training grant in 2014 from SAMHSA. And very quickly thereafter, we started our sustainability planning process. In some sense, I started building the business case for the program at that point in time. And if there's any single piece of advice I can give to folks who are on this webinar, it is to start as early as possible. You will need the time to lay the case. And so that involved meeting with leadership here at Rush to really talk about what the future state was going to look like. And we were at an early point in our grant, but we knew SBIRT worked. We kind of knew that, that the methods here had a substantial evidence base, and that, there was going to be a case to be made here. But I personally actually learned a lot about how to write a business plan in the course of having these discussions with administration. In 2017, we completed the training phase of our grant. We've been on a one-year no-cost extension since the fall of 2017 to do our follow-up data as required by the original grant. We exceeded the number. We had sort of committed to training 432 nurses and medical residents. We went well above that in our grant, and our grant eventually expanded out to train medical students and social workers and PAs, and we hit a lot of disciplines because Rush is a large training institution. In the fall of 2017, just as our sort of formal portion of our training grant was ending, we launched what we call here the Substance Use Intervention Team. And this team now houses our training program and expanded services substantially. And the outcomes of that program have started to emerge this year. I'm going to show you some of those numbers. But the Substance Use Intervention Team really is an approach to operationalizing SBIRT at our hospital, where we screen all patients that are admitted to Rush Hospital for substance use disorders using an SBIRT model. And it relies on multiple specialties. So the model actually has the frontline nurses who are doing the admission, as part of their admission battery, ask a couple questions, and that will then trigger off, depending on the answer, consults to social work and to a dedicated substance use consultation team. So if you want to see details of our program, we actually have a website, and it has a lot of our materials. A lot of our training materials are housed on here. You are welcome to download, reuse, and pull for whatever you like. So this is how our substance use intervention team looks. We have a 2-question nursing screener that asks about alcohol or other substances. If either of those are positive, it will kick off a social work-driven, more extended screen. So if they answer yes to the alcohol question, we use the audit. If they answer yes to the substance question, we will use the DAST, and the DAST trumps the audit, if that makes sense. So if both questions are positive, we will only do the DAST then. And the social worker will come by and do this more extended audit or DAST at the bedside, and the floor social workers all trained in SBIRT as part of this implementation, and have been great at doing that. Now, look, floor social workers are stretched, the time is limited, so we have to actually back them up with some additional social work staff that exists on our team, and they help fill in the gaps. So if one of the units is really getting hit very hard, our social worker, will get paged by them, and they'll say, look, we've got a lot of admissions that came in last night. Can you come up and help out? And our team will go in and fill in and help with that. And that has really built a lot of great esprit de corps with the hospital social workers. If indicated, the social worker will actually then generate a consult to our astute inpatient consult team here in purple. And that team is a multidisciplinary team that includes an attending physician, and that person's boarded in addictions, social work. We have a psychiatric nurse practitioner who's on that team, and we also have a clinical pharmacist who's part of that team. And depending on the needs of the patient, different members of that team will go and do the consult. So they're really able to kind of hone in on what's needed. And then this program then feeds into these outpatient clinics that are here shown in yellow. The outpatient clinics have 2 forms. One is a more standard addiction medicine clinic where we just focus on addiction issues. And the second is what we call the RAMP clinic, which stands for Rush Addiction Medicine Program. That is actually our dual diagnosis clinic. It has that historical name, hence why we've kept that. So this has been a really successful program for the hospital since our launch. Within 6 months, we were able to show value on this program. And let me see if I can show you this. This was the sort of year one staffing of our program with a $680,000 initial budget. So this was the budget I fought for 2 years. This is what all that initial sustainability planning that I started in 2015 led to. It led to a commitment from the hospital to fund this program. And it involved these FTEs, basically. That's what that budget supports. And so, you know, I put this out there for all of you. You know, I'm happy to share some of our numbers, you know, to the extent that I can. But this is what it bought, was like basically 3 days a week of an addiction medicine doc, a half-time psychiatric nurse practitioner, who we share actually with the psychiatric consult team, which is just incredibly useful. And I'll show you some data about what washed out of that, because there were certain anxieties and fears initially when we were launching this program about us pilfering patients, which didn't happen. And then we have a half-time clinical social worker, a half-time clinical pharmacist, a full-time nurse coordinator in our clinic, and an LCSW who's full-time. So this is actually what 6 months of data came out to in our program. So during that time, there were over 16,000 patients that were admitted to Rush Hospital. These are unique patients. We screened over 90% of these patients. So this is actually January through June of this calendar year. Of that, you can see how things washed out in terms of positive. You know, over 6% were positive for drug misuse, over 12% positive for alcohol misuse. A subset of the drug misuse was our opioid use population. We've been paying particular attention to this because we were fortunate to get a sub-grant from the state of Illinois to support some of our activities around opioid use, and it reduced even though the hospital had made the commitment to $680,000, they didn't actually have to foot that full bill because the state actually gave us about $200,000 or something of that ilk to support specifically opioid use disorders. And then you can see, you know, how many patients. We did, our social work folks did about over 500 consultations in the hospital, and the SUIT team, the medical and psychiatric nurse practitioner team, that multidisciplinary team did 372 consults in that 6-month period. We started 43 patients on buprenorphine in the hospital, all right? These are patients who otherwise would not have been started on that medication or that treatment at that time. So this then rolled into our outpatient clinic. So these are our real outpatient numbers of this year, and how many therapy visits folks came in for. We are expanding this clinic dramatically in year 2 of our program. But we have a relatively good show rate, actually, and our retention rate is relatively high. This has gotten the attention of some officials here in Illinois at the state, and it's because my team stalks these patients. We call them and hound them, and they come in. But this is where we land patients regardless of payer. So we're sort of agnostic to the payer when we see these patients in the hospital. And even if we're not contracted with their insurance or with their entity for outpatient care, if we can't get them a follow-up appointment with an in-network provider in a reasonable period of time, we will land them in this clinic for follow-up care, just because we want to make sure that if we're starting them on buprenorphine or any other medication-assisted therapy, that they're getting the treatment that they need. Now, this was a hard sell to the hospital, because this clinic, if you look at just this outpatient clinic's financials, they're horrible. They don't pay for themselves at all. But the yield comes in this. So one of the things we were able to show is that we reduced length of stay. And there's some, you know, things in here, people who do this work will recognize this stuff. But the number was a little inflated on this first interval. So this data actually shows November through March, that 6-month period, and it shows you 0.8 of a day, so 8/10 of a day, which is remarkable if you play in hospital budgets. That's huge. It turns out, I think, as I've looked at the data more recently, we're probably at about half a day. And half a day is really good. Mind you, don't shy away. If you get half a day, you're in good stead. The reason why I think it was so high initially is that we picked off some really tough patients that had some significant issues, and sort of the low-hanging fruit was worth more in some ways. But we're at about half a day now, and that's what I'm planning forward on. We also reduced 30-day readmission by about 2%. This ends up being, for the hospital, if you just look at the patients who got the consult, the 161 patients who got a consult, that ends up being $1 million right there, all right, in terms of how much our service saved, specifically saved for these patients. But if you look at the impact at the hospital more broadly, we're well in excess of a couple $1 million that this program saves. So I think this is the case that you need to be talking about with hospitals. You know, if you're in a healthcare setting and if you have the opportunity to, you know, have input into building a clinical process and aligning the training and curricular needs that you have with that process, this is the case, basically. So now in the state of Illinois Department of Public Health wants to take this and push this to all the other hospitals here in Illinois and say, look, you should do this because this will save you money, and it does. And we compared patients who didn't receive the consult. Now, people ask us about these patients and how, you know, why didn't they receive the consult? So initially, when we first rolled the program, in the initial months of the program, we were only screening about 60 or 70%. It's been a process to get up to 90%, you know, and that's working through all of the hospital workflows and making sure everybody's trained and everybody feels comfortable doing this. So we had to work towards that goal. So there was some lag. And then part of it is also there are some patients who just don't report actually that they are using substances. They're afraid to on those initial screens. So if they don't report it as part of the screening process in that initial thing, they might not get it, even though it might appear later on their problem list. So we used what was their diagnoses on the problem list that to create the comparisons between those who received the consult and those who didn't, and to match patients. So some of that is a you know, why there's a number that don't. But we feel like that's actually a fair comparison because the hospital has a number of initiatives that are trying to address length of stay, and we really wanted to try to focus on the impact of our initiative specifically. So that was why we developed this method. But we are looking at other ways to analyze the data as well. This is what happened in terms of sort of referrals and consults to the various units in the hospital. And basically the take home from this is that we generated new consults. The green lines are actually new consults. So if you look at sort of the blue and the red lines are the psychiatry consults before our service emerged and the psychiatry consults after, you see that there isn't a lot of shift actually. You know, where there's a blue line, there's a red line that's almost the same height. So the fear was actually our colleagues who do, you know, traditional psychiatric consult services were worried that we were going to steal their patients. They were not seeing these patients. These are new patients that are getting a new service, is what comes out of this. And this was actually kind of what showed up in terms of looking at length of stay. So the average patient who has a psychiatric comorbidity, this isn't going to surprise you, has a significant length of stay. You can see here that their length of stay, if you have a medical diagnosis and a psychiatric consult is placed, your length of stay in the hospital is about 12 days, you know, based on what we found in terms of looking at this. And the average time between when the patient is admitted and when they get the consult to psychiatry is 4.5 days, okay? So this patient's sitting in the hospital for that period of time and not getting services. Here's why our service actually reduces length of stay. Down here, if you look at the consult to addiction medicine, 1.8 days to get that consult done, right? So that means the patient only sat in the hospital for 1.5 days before the consult was placed. And you can see our length of stay is half of what it is to psychiatry. And the reason for that is we automated the screen. The screen is taking place at the time of admission, and it just kicks off. It doesn't require the team to come in and the doctor to say, or the resident to think about, oh, am I going to place the consult or not, right? we moved the bar far earlier. So it was really to our advantage to have SBIRT, kind of that model, baked into our system here and to be part of what we're doing. So this is our staffing as of this year. So I went back and I showed the length of stay data, and administration here, I got no argument, you know, which means I didn't ask for enough. But basically we are doubling our team size, you know, and we're going to really effectively now staff this clinic. We are going to keep that addiction medicine outpatient clinic as an insurance agnostic clinic. We don't take outside referrals to that clinic. That clinic really exists to service the patients who are coming from the hospital and to land them into a place where we can take care. And then we try to, if they're not in network for us, we schedule their appointments with other providers and, you know, in their systems of care, and we will hold them in care until we can get them to that appointment. So that it's a bridge clinic that's designed specifically for this purpose. But we're going to be able to basically expand care to, you know, 4 days a week of medication treatment, 5 days a week of therapy, and full case management. And we have a great team that's really gotten behind this. And so senior leadership here is very much in support of this. So thank you. I'm happy to address questions, Brian, you know, as they come up.
Thank you very much, and you know, special thanks again to all 4 of our presenters, Carlos, Ann, Marianne, and Niranjan. Before we go to questions, or actually go ahead and put those questions in the chat, please. I'm going to take care of some last business here, and then we'll do our questions. We ask everyone to please complete the webinar evaluation. You can see the link there, but I'm also going to place it in the chat. It might be a little bit easier for you to copy and paste it from the chat, or just access it that way. If you would like a CEH certificate for participating today, you do need to complete the evaluation. And if you want to follow up with me about that, just complete the evaluation and then send me an email, and you can see my email address there. I'm going to put that in the chat also. So with that, let's review the questions here. I saw one come in earlier for Carlos. I'll read it here, and then maybe we can get the questioner on the line also. So Carlos, the question was, you were talking about baking in SBIRT when you were talking about partnerships, and can you talk a little bit more about what you meant by that?
Yeah, absolutely. And so I think that there's, you know, baking in can happen in different places, and it's different parts of sustainability when we think about institutionalizing curriculum. And I think this is maybe because I'm hungry now because it's lunchtime, but when I think about students, our cake, right? So they are the cakes that come out of our training programs. You know, to bake it in would mean how do we adjust the recipe? In the case of training programs, it could be adjusting curriculum, right? How do we change the curriculum and institutionalize SBIRT training in the curriculum to bake it in, right? And I think Marianne was talking earlier about the effort she's doing to put it into first-year curriculum, and so that's one example. When it comes to partnerships, you know, things to think about are learning contracts. You know, is there something in the learning contract that you have with your field placements potentially that asks them that this is one of the requirements, right? And so again, you are modifying agreements that you may have with field practice or internships to really ensure that SBIRT is a component that is done and monitored. And so that's one example of baking in.
Brian, I don't think we're hearing you if you're talking.
Whoops, muted myself there. There was a question from, thank you, a question from Stephanie here. Where did the funding for the program come from for your program again? I think you mentioned the state, but was there another source you mentioned?
Yeah, so the hospital underwrites the budget of the program. So basically, that initial outlay of $680,000 was committed to by the hospital after I did 2 years of convincing them about the program and presenting the business case for this. We did get an additional grant after the budget was approved from the state of Illinois, specifically to expand some of our treatment capabilities around opioid use disorders. So that actually kind of reduced the exposure of the hospital on that initial year. And it also actually allowed us to launch an addiction medicine fellowship program here as part of another training program. So that was part of our commitment to the state. The state has, been a really great partner in terms of helping us to build some of these programs and to launch them. And we've been in discussions as to how they could generalize some of that support to other hospitals as well.
Thank you. Any other questions? You can raise your hand or send in a chat. By the way, if folks are interested in a copy of the presentation, we can share the PDF version, and you can email me and I can send that along. Also, in the listserv yesterday, we shared a copy of the sustainability tool that a number of the presenters referenced. And if you didn't get a copy of that, let us know. We'd want to share that with you as well. So
Brian, somebody made a comment about publishing the data.
Yeah.
Actually, the outcomes data has been submitted actually for publication. We're waiting to hear back on that. I haven't kind of put together the financials yet, but I'm going to be working on that soon. I wanted to get like a full year on the program, so in order to get the financials sort of, to extend to that period.
Great.
But yeah, we're working on that.
Excellent. Yeah, well, please, when that gets going, keep us in the loop and keep STAMPS in the loop.
Of course. While people are thinking about some of their questions, I will say, I think that the data that we have is comparable for other academic institutions that are, like us and of that size, or hospitals that are of this size, really. I think it's hard to generalize these types of numbers directly to other size institutions or hospitals. So one of the things that I'm very cognizant of is that, we don't have a good sense of the return on investment for smaller hospitals or for entities, that are of a different sort. So we need to replicate this in some ways in partnership with other entities. Like, we need to track SBIRT as it's done. When I originally went to build the business case for this, I dug into the literature, and it was, aside from some of the SAMHSA reports, and then in the SAMHSA reports they cite return on investment like 6 to 1, but those are like global, returns to society as a whole, right? You're reducing incarceration, you're reducing other things. And the hospital bean counter said to me, no, we want to know what the impact is on our hospital. Mm-hmm. And I ended up using a number that I found from a study of an alcohol intervention in the UK, because they were the only ones that really published specific numbers about their hospital. So it's very hard to get this, and most hospitals are pretty guarded about these types of financial numbers. I even had to go to the dean to get permission to share some of this stuff, because people were like a little anxious about this. And I was just like, look, there's nothing in this that really reveals anything about our hospital's business strategy or anything, right? I mean, it doesn't hurt us, and it really would help other places to know what the return is. So I think you need to think about that and sort of what your institution size is, and then some of these numbers might make sense in terms of comparison. And you also need to think about your base population. So, Rush is located on the west side of Chicago. We have, a relatively, we have a diverse payer mix. We have, about a third of our patients are probably fee-for-service, and then 2/3 are government payers, with a third being Medicare and a third being Medicaid. So the hospital actually sees a wide range. But other hospitals with different mixes and different patient populations this thing might swing, in different directions in terms of its impact. depending on who you're working with and depending on how your SBIRT program is operationalized. But I think having those discussions early is critical, and we couldn't have done this without support from our information services team, because they really helped us build it into the EHR, and that's where the success of the program really comes from, is the fact that the system kicks it off early and helps the individual providers to do this they don't have to think about it. The system is prompting them to do this.
I do have a question here for Dr. Amodio. Let's see. So there was a training for the field instructors, and then there was a regular SBIRT training for the students. How are those trainings different? Like, for example, did the training for the field instructors have material about like supervising and continuing to develop SBIRT skills and competencies in practice? Was it different?
Excellent question. We assume that the field instructors already have good supervisory skills, if not excellent supervisory skills. So the SBIRT module for field instructors did not try to focus in that area, but it did clarify some issues. You know, if students are concerned about when to apply SBIRT, here are some guidelines. Or if the agency feels it's inappropriate at the intake stage, here are some other times when it could be, you should encourage the agency to allow it to be used. So what was directed to the field instructors was some limited material on organizational integration, I guess is what you would call it. This kind of overcoming agency barriers to using it, or addressing your students' concerns about using it.
Great, thank you. Well, we're about out of time. I think we can fit in one last question, but for those who need to leave, that's okay. Again, please fill out the evaluation, and again, thank you very much to our 4 presenters. I'm going to try to fit in a last question for Dr. Karnik as we're kind of closing out here. Where did it go? Dr. Karnik, I'm going to give you a double question. What electronic health record software is your hospital using? And at Rush, were you able to bill for SBIRT screening and brief intervention services?
Great question. So we use Epic here at Rush, and that we have a great IS team that really has done a lot with that system, but I think that this build should be doable in many EHR systems. About billing, actually, the SBIRT codes in Illinois are not open under Medicaid. And in an inpatient setting, you wouldn't necessarily bill independently for these actions. Most inpatient admissions are driven by a capitated model that the hospital gets paid a certain amount per day for the admission, and that's it. And they're usually a contracted amount with the federal government or with the payer. So our team actually, we diagnose and bill in order to show our RVU activity in the hospital, but none of that is how we get paid. So the hospital just underwrites this service now as being like a core service at the hospital. It's just in their overall budget. And because of the length of stay numbers that we've been able to kind of consistently demonstrate the impact on that, this is just a financially logical model for them to use. This will look very different as we roll to the outpatient side, where billing and sort of, generating revenue for specific actions can have impact. But even there, I'm hoping that we can show, an impact on the actions of other service providers and be showing the support that we provide to them. I mean, look, it just makes sense, patients with substance use disorders cost our system in various ways, lots of money. And I think the trick with this for us is really, let's find the places where we can use that to leverage the support of the programs that we know make sense. So that's the end of the day here. And look, they make sense because they're providing good care to patients, and the patients are more satisfied, the outcomes are going to be better, and that's the direction our system has to move in.
Great information. Thanks so much. Well, this concludes the webinar. Thanks again to our participants, and special thanks again to our presenters. Take care, everybody.
Thank you.
Thanks.